Good day, everyone. I'm Xanda Hilger, and I coordinate North Central Texas Caregiver Teleconnection through the Area Agency on Aging of North Central Texas. Our guest speaker today is a pharmacist, and she is going to talk to us about the idea of polypharmacy, and she's going to explain more of that later. But polypharmacy is what many of you as caregivers may be experiencing, because the person you care for, even yourself, may be taking multiple medications from multiple doctors. And I've had that experience this year myself of having multiple doctors going from a vanilla file folder. I now have a 3-ring binder. So Becky's going to talk to us about what this means and why it's so important that we as caregivers especially understand how our responsibilities have to sometimes shift when there are so many doctors involved and different types of medications. So that said, I'm going to turn it over to Becky Mahan. Becky, hold on just a second, because I haven't. These folks need to know more about your qualifications or your background. She is a pharmacist, and she has many initials after her name from her specialized training and certifications. She is Assistant Professor of Pharmacy Practice of the Geriatrics Division, Jerry H. Hodge School of Pharmacy, Texas Tech University Health Science Center in Abilene, Texas. That's quite an introduction. That's quite a title to have. Becky completed her training at the Health Science Center. She received her doctorate of pharmacy in May 2012 from Butler University and completed a community care residency with Penobscot Community Health Care in Bangor, Maine. Her interests include Alzheimer's disease, diabetes, caregiver support, ambulatory care, home-based care, and academia. Dr. Mahan is a member of ASCP, ASHP, and Kappa Psi. And please tell us what those are. She loves working with geriatric patients. That's where her passion is. Thank you for joining us, Becky.
Thank you for the introduction, and you're very welcome. So some of the things you just mentioned, one is American Society, ASCP is American Society of Consultant Pharmacists, and they do actually have a tool when you were just talking about trying to talk to a pharmacist, that you can go on there and try to find a consultant pharmacist in your area. So they do have that, and we could potentially share that. I didn't think about that in advance, but that's ASCP is one of the organizations I work with, mainly pharmacists that work in the geriatric arena. ASHP is American Society of Health System Pharmacists, so provides a lot of education, what's changing in the medication world, in practice, kind of helps pharmacists in all different arenas. And then Kappa Psi is a professional fraternity. So not the social ones, but professional, and helps you really network and stuff in that arena. So I will start sharing. I put together kind of a small PowerPoint today to help us go through our thoughts, but I'm definitely open to any questions as we go. So let's get this started. Are you all seeing just the slide, or is it showing you the speaker?
Yes.
Okay, awesome. All right, so more explaining some credentials that are on here. So the Pharm.D is that I'm a doctor of pharmacy. BCGP says that I board certified in geriatric pharmacy. BCACP is ambulatory care. So she mentioned that I did community practice. So really focus a lot on outpatient versus the hospital. That's never been my thing. And then FASCP is that I'm a fellow with the American Society of Consultant Pharmacists that I mentioned earlier, which is just an indicator that I've been heavily involved with the organization and in service and stuff for geriatrics. And we do have probably the longest title possible for our school. We abbreviate it with as much letters as we can, but it's still a lot. So what I'm hoping that we can discuss today, first is just the what is polypharmacy, because I think often when we say that, we all have slightly different definitions for what it actually is. What are some common drug interactions in older adults? And ultimately, how can I prevent or prepare for potential drug interactions that could occur? So kind of trying to take that proactive approach for knowing what might happen and what to do about it if we identify that. So you hear the word polypharmacy, and there's various potential definitions that you might hear. The standard one that you usually see is the use of 5 or more medications. Now, older adults, 5 or more medications, when you think about the fact that medications includes over-the-counter products, so it would include your multivitamin, it would include vitamin B12 supplement, it includes all those different things that you're using. If you're using Tylenol as needed for pain, that counts. So probably if we're using this definition, everyone meets the definition of being with polypharmacy. So I really think about it more being, do the medications make sense or not, versus that 5 or more. You'll see some that would say that it's the use of multiple pharmacies. And the reason it might fall into saying that it's the use of multiple pharmacies is using one pharmacy, if you are able to, is going to help with safety. And that's because if you're using that one pharmacy and they have a true appreciation for everything that you're filling, and if you potentially ask them, I'm also taking these supplements or over the counters, can you see if there's any drug interactions? They're fully aware of what you're taking. Your insurance company keeps track of what they are paying for, but if something isn't paid for by your insurance, they're not necessarily going to catch that. And so if you're paying cash for something at one pharmacy and then insurance at another, they're not necessarily communicating through the insurance. So it doesn't always catch in that fashion. Or the definition that I prefer is just the use of more medications than necessary. So they're taking medications that maybe you don't have an indication for, that you don't need to be taking, or that you're taking a medication that you only needed to take it for a short amount of time and you're still taking it after that, or you're taking it from a side effect of a different medication. So there can be multiple reasons why we're taking more medications than we really have to. And generally, these are things that we would consider to be polypharmacy. Now, one of the biggest contributors to polypharmacy is something that we refer to in the health arena as prescribing cascades. Now, this one, I thought it seemed a little straightforward to understand. Some of these are written in a lot of language that are not easy to follow, even for myself sometimes, what they're trying to illustrate. But what a prescribing cascade is, you start a medication. And so for this one, it says that the person has depression. So they've started bupropion to take depression. When you start bupropion, it's very activating. So this individual starts having insomnia. Now, instead of addressing the fact that your bupropion started insomnia and potentially saying, let's change it to the morning, or it's twice a day often, so let's not take that second dose after 3 p.m., the provider immediately jumped to, let's start another medication. So they gave this patient or encouraged them, potentially they even did it themselves, to take a sleeping pill called Sleep Ease, which is basically diphenhydramine or Benadryl. So now they've taken this medication to try to treat the insomnia. Now they're going to have new side effects such as dry mouth, constipation, foggy brain. So for any of these, you can see, dry mouth, they might start just drinking a lot more water or kind of sucking on candies. They're sucking on candies a lot, then it could increase their blood sugar. So you can see how that could continue. Constipation, there's a ton of medications we could use for constipation. So those may play in, then that might give you diarrhea, and you can see how the circle continues. That foggy brain, if that really comes in, people might start getting worried. Am I experiencing dementia? Is something else going on? But this is a true prescribing cascade where we could have stopped it right at that first thing of asking, is bupropion the best medication? And if it is, then let's see if we can just change the time of day and kind of determine how long are we going to see if this is appropriate or not before we change to another medication, instead of automatically adding more meds. Okay. So another thing to consider is common drug interactions. So when we think about drug interactions, drugs can interact with a lot of different things. So you want to think about what all could they interact with. So they could interact with other drugs, and some databases are just going to look at how is this drug interacting with other drugs. They could interact with food. So that could be that you're supposed to take it on an empty stomach, or you're supposed to take it with certain types of food. There's some that are, you're supposed to take it with really fatty food, or you're supposed to take it with protein. So seeing if that's included. There are potentially interacting with supplements, and it can also interact kind of really with the person, but it's specifically their disease states. So one that people often think of is, are your kidneys working and your liver working well? Because if they're not, then we could lead into, you'll sometimes see it referred to as contraindications, or kind of wanting to worry about use, but it's really those disease states themselves that contribute to the drug not being a good option for you. Now, there are a lot of medication drug interactions, and so I wanted to try to think of what are some common ones that I see that you could, if you knew just a couple, know that these are ones that often have drug interactions. A big one is antibiotics. And so antibiotics, they often can have, for our older adult population, not as important, but for younger individuals, they can interact with birth control or different forms of hormones. They often have different food interactions. So like doxycycline, you're not supposed to take it with calcium, with iron within, I believe it's 4 hours. So you're supposed to separate that from potentially when you're eating or taking other supplements. Metronidazole is on there because this one actually has an interaction with alcohol, and it can last a little bit longer after you've taken that medication, that you still can get really bad nausea and vomiting after taking that antibiotic. Drugs that alter heart rhythm. A lot of these, because they are altering heart rhythm, we just need to be cautious if we're on other medications that can also alter our heart rhythm. So amiodarone, fluconazole, antipsychotics, these are some of the big things that fall into this category. Sinemet, so for Parkinson's, we use Sinemet very often, and so carbidopa, levodopa. This has a big interaction with protein. So you're actually supposed to limit how much protein you take with it when you're taking this product, but just at the times you're taking it. Protein, we know, is an important thing to consume, but just trying to limit how much protein is being consumed at the same time as the medication, because it won't work as well. PPIs, proton pump inhibitors, if anyone has ever taken those or ever read the insert for it, they do recommend that you take that when you first wake up, when there's nothing else in your stomach, and waiting about 30 minutes before eating, drinking, or taking other medications, just because it won't work as well if it doesn't get that time by itself to really work in the stomach. Bisphosphonates is another one here that has those very specific timelines on it. So this we use for osteoporosis, it's like the words, the bones, but osteoporosis. And so this is another one that you're supposed to take it and then not take anything else for about 30 minutes. And so that's one that we often see too. And then another one that has lots of drug interactions are your anti-seizure medications. Now, they might be used for other things, but they are considered to be anti-seizure medications. And these include things like carbamazepine, valproic acid, lamotrigine, etc. So these often will alter how the body is able to metabolize drugs. And so they have a lot of drug interactions with other drugs, being that they either could make them not effective or too effective. And so we would need to think about what they're being used for. And sometimes we even have to change the dose of a medication you've been on for a really long time, just because of that addition of a medication. Now, with these common interactions, they can be interactions at the beginning, or they can also be interactions that maybe at the beginning it's not that big of a deal, but over time they become important. So I had a patient just this morning that we were working up, and they've been on some big offenders. They were on a medication for, it was citalopram, so one of the antidepressants, and a beta blocker, sotalol, so something to help with their heart rhythm. And both of those medications can, as I mentioned, if things are altering heart rhythm, that can kind of be additive. And so when she started this, it wasn't as big of a deal. And so I kind of just continued to monitor, but now we're actually starting to see they are interacting and not in a healthy way. So now it's an interaction that I'm worried about versus before it wasn't too big of a deal. So now I've approached the provider to try to change it. So realizing they can kind of become an interaction at any point in time, not always just at the beginning. Now there is a tool that is currently available. So if you have any interest in these type things, I would encourage you to go and grab this tool before they lock it, because they will soon, that you won't be able to access it without a subscription to their services. And this is the Beers criteria. So the Beers criteria was just updated in 2023. And it is specifically for medications that it's really just about medication use in older adults. So there's various tables, and the one that talks about interactions is table 5. And so on the next couple slides, I've kind of summarized what those actually say, but there's different parts in here as well that tell you, which medications are not appropriate in certain disease states, which medications cause anticholinergic side effects, which we'll talk about in a little bit. But it's a really helpful tool just to kind of see what might not be appropriate. It's not to say that it's never appropriate or that's always bad, but it just kind of helps clinicians try to see what are better options that we can use for older adults. And it is currently available if you wanted to try to look at the Beers criteria. It just came out, I think, in just like April or May. So it's very recent that they updated it. Now, this is just an abbreviated version of that table 5 that I mentioned, but just to show you kind of how they are specifically talking about what are some drug interactions that are particularly concerning in older adults that maybe we don't think of in people that are younger or even kind of middle age, that it's not as relevant. A big one is opioids, and then the use with benzodiazepines, so things like lorazepam, alprazolam, we mentioned earlier, sometimes animals too, need those during storms, gabapentin and pregabalin. So when these are used together, there's an increased risk of overdose, an increased risk of respiratory decline, and an increased risk of sedation. So this is not to say do not use these together at all, but just knowing there is an increased risk, kind of thinking before we use all of these together, do we truly need to? And with this interaction, it's more if they're just used on an as needed basis, that you're taking them scheduled. If for some reason you needed these different agents, the body will kind of adjust to it. You're not as likely to have that, but it can be cumulative sometimes. And that's why they mentioned that risk of overdose. If people are taking too much and the body's not getting rid of it like it should, that's why there's that increased risk of overdose. Now, for this drug interaction, there is actually a medication available for that. And so the medication is called Narcan or naloxone. And naloxone is available at pharmacies. So you have to go and ask for it. And it kind of varies by state how it's accessed. But that is something that's available. It's a nasal spray, the one that's over the counter. Well, I say over the counter. It's not over the counter yet, but it will be by the fall. So it's currently behind the counter at pharmacies, but it's going to be going over the counter. So it'll be something in the fall that you can just go to a store and purchase. But this is for opioid overdose. So it's something that you can have in case someone overdoses. Lithium. We don't use lithium all that often anymore. But if you are using lithium, this really is very dependent on the kidneys. So to be able to maintain your lithium levels and how much is in your body, your kidneys need to be functioning well. And so some of the medications that also impact your kidneys are ACE inhibitors, ARBs, so things like lisinopril. For ARBs, those are ones that end in sartan, so losartan, valsartan, loop diuretics, so things like furosemide or Lasix, All of these, because they are also working on the kidney, has that increased risk of lithium toxicity. Mainly because the lithium toxicity here, the lithium concentrations are higher, so you have more lithium in your body because these agents are trying to help you get some of the water out. And so that's basically how that one works. Non-selective alpha blockers and loop diuretics. We don't use these very often either because we use much more selective alpha blockers. And this is something that is used in BPH, so in benign prostatic hypertrophy, that this one is used because it helps to actually kind of make it easier for someone to urinate. And so the non-selective have various places in other parts of the body too. And so they don't recommend using these two together because a loop diuretic is helping you get fluid off, plus the non-selective alpha blocker is helping to kind of loosen the body saying it's not time to urinate. And so when you're using these together, they have found that in women, it actually increases the risk of urinary incontinence. So they say not to use those two together. And then we always hear about bleeding being a big thing to watch for interactions. And bleeding is because the Beers criteria is only focused on what's more relevant in older adults than it is in other populations. It actually only specifically talks about warfarin. So there's a lot of other medications now that also can cause bleeding, but warfarin we have to really monitor pretty closely compared to the others. And so some of the medications it mentions here are amiodarone, and I mentioned amiodarone earlier because that can also cause some things with your heart. Ciprofloxacin, so one of our antibiotics, Bactrim, the sulfamethoxazole, trimethoprim, and SSRIs. So this was an interesting addition. So your SSRIs such as sertraline or Zoloft or escitalopram, Lexapro, these work on platelets, which then contributes to the blood being a little bit thinner. We don't usually consider it to be a true drug interaction, but they have said in this latest update of the Beers criteria that they would consider it to be a drug interaction to consider that when prescribing warfarin with an SSRI. So they may recommend that people use a different antidepressant if they could, if they need that warfarin. But there are a lot more medications now in the blood thinning realm that we would probably use instead if we needed to avoid that interaction. Now, the other one that they had on here was anything that is CNS active. So CNS active is going to be things that are working in your brain and can make you dizzy or tired. So medications like this could include your anti-seizure medications, antidepressants, antipsychotics, Z drugs. So Z drugs are used for insomnia, and they include Zolpidem or Ambien. Lunesta is esopiclone. And there's a third one you don't see very often, but it's called Zaloplon. The brand name is Sonata for that one. Opioids and muscle relaxants. And so they say watching out for these because of the fact that it makes us tired, makes us kind of dizzy, and just kind of not moving as quickly. There's an increased risk for falls and fracture. So the recommendation the Beers criteria has is to limit to less than 3 of these. I don't really know where they specifically came up with 3, but that's their recommendation. And so across the board, not taking more than 3 CNS active drugs is the recommendation that they have made. And people would be able to help you in identifying which ones are if you're not sure and you're trying to see if you have more than 3. Now, the other thing that they mention is anticholinergics. So anticholinergics are CNS activate, they're CNS depressants, but they also have a lot of other side effects. So this visual on here is just kind of a picture we use in medicine to try to remember what are the anticholinergic side effects we anticipate. So that hot as a hare, dry as a bone, blind as a bat, red as a beet, mad as a hatter. So it causes cognitive decline, falls, fractures, delirium very easily. So this can kind of, they might start thinking, oh, does this person have dementia? And it's really just delirium related to a medication that's very anticholinergic that someone is using. So they cause a lot of side effects, and generally they're just not great for older adults if we can try to avoid them. Now, what medications are anticholinergics? This is a little blurry, but again, if you pull that list, you'll be able to see it more. So this is table 7 from the Beers criteria. And this gives an example of medications that have strong anticholinergic properties. So some on here that may stand out, let's see. In the antihistamines, diphenhydramine is probably one of the biggest ones that we have. So diphenhydramine is Benadryl. It is very anticholinergic. It's also very accessible, and very much in products we may not realize that it's in. Most of your products, if they say PM, it is whatever that product is plus some Benadryl, and we don't always realize that. And so it can cause a really strong anticholinergic, almost hangover type effect. Benadryl is one of them that I remember. I'll also hear people kind of mention it being a pink pill, because for some reason, if it's plain Benadryl, it always seems to be hot pink in some variety. There's usually pink involved in your Benadryl products. And so my grandmother, she had dementia, but we would just go over some days and she was just really out of it in the mornings. And we kind of couldn't figure out why she was so much worse than she was when we had just seen her. And then she was with it enough that she told us one day, well, the nice lady gave me one of those pink pills last night. So she was living in an assisted living and she had some Benadryl that we had put in her cabinet due to an allergic reaction before. And we forgot that it was there and hadn't cleared it out of her cabinet. So when she was having difficulty sleeping, they were giving it to her for that as well, since that's something that it could work for. And then we realized that it was those days that she was getting that nice little pink pill that then she was very out of it in the morning. So we took those out of her cabinet, but you could really see that impact that it had. Other common ones that are on here, the urinary incontinence medications. So oxybutynin is probably one of the other big offenders. When it comes to oxybutynin, the oral that is immediate release, so it would probably say IR on it. That one's more than the ER. So if we have to use one, then we would prefer that. And the patch is probably pretty negligible because we don't have as much absorption. But that's another common one that we see. But those are probably the biggest ones. You can see on the antidepressants, there's some are more anticholinergic than others. So one like paroxetine or Paxil, we try not to use that much in older adults because it is so anticholinergic versus some of the other antidepressants I've mentioned. Now, what are some ways that we can actually manage and prevent drug interactions? Because I think this is really the biggest thing is we know there's all of this information. It's overwhelming. What can I do in this situation? So I just have some tips for what you can try to do. And I'll tell you about some websites too that I looked at to see what they looked like. So having a current list of all medications you or those that you care for take. And so include in those things, like I mentioned, of what multivitamins are you taking? What supplements are you taking? If you're in pain, what medication would you go take? Because even if it's just as needed, it could be a drug interaction that we would want to think about as healthcare providers. Fill all of your medications at one pharmacy if possible. I know also people often try to utilize drug savings type programs. So if you get samples from a provider, or if you're able to get them from the manufacturer, but they usually mail those to your provider, you want to make sure that whoever is filling your medications knows about those as well, because that's not getting reported to them. So if you get, I think of some of the common, maybe like your insulin might come through that way, then you'd want to make sure that they know you're on insulin. I mentioned blood thinners being a big thing that you often can get. And you can get those as samples or different drug assistance programs. So making sure that whoever is filling your medication, so that pharmacist knows as well that you have those. Ask the prescriber or pharmacist in advance for any potential food or scheduling interactions. So that can be something just asking, how is it best to take this? Is there a time of day? Should I take this with or without food? Is this going to interact with any of my other medications? So knowing that up front, so you can kind of avoid it as you go forward. Review the package insert. Now, the package insert, they're working on trying to make these friendlier because they're a lot to read. Even as a healthcare provider, I read some of them and there's just so much information, but not always the most relevant information, kind of like, well, it could cause this in less than 0.1% of every patient, but they still have to put it on there because someone has experienced it. But there is often parts on there that will tell you about administration, so how to best take those medications. And then be familiar with the classes that we discussed today, because those are kind of, if you know some of those classes, it's helpful to know which drug interactions you might be anticipating. Now, if you have a list and you're curious as to what interactions might actually exist out there, there are a couple tools that are accessible through caregivers and patients to try to look at their own. Now, I put 2 links on here. One is the drugs.com. So drugs.com, you enter the medications that you're taking and it generates a write-up. So when you're making this write-up, it then will let you say, is this a consumer or a professional? And so you can see that it's written a little bit differently for how it goes into those. It's pretty lengthy, the information that it puts on there, but I know even when I was looking at myself as a healthcare provider, being able to look at it and say, well, I mean, that's a potential drug interaction, but really not something that I necessarily would say, don't take those together based on how it comes up. So it's kind of just an initial information. Then there's WebMD. And so WebMD also has an interaction checker. And when I did this one, just note that it seems to really focus on drug-drug interactions. So compared to what I was seeing on drugs.com, compared to WebMD, is there was a lot more information in drugs.com that was popping up. You're probably wondering what on earth this Han code picture is in the top corner. So a Han code, and generally this is going to be all the way at the bottom of a website, indicates that they have signed up for and agree that their website is medically based. So it's saying that we know that this is appropriate medical information. And if this isn't there, it doesn't mean that it's definitely not medically based, but it means they haven't tried to get this certification saying that it is medically based. So this Han code you can just look for. It looks just like that, and it's usually all the way at the bottom of a website if they have decided to actually enroll in that program. And I can't remember off the top of my head, but one of these doesn't have a Han code. And I can't remember which one it is. But so just go all the way to the bottom of the website and you'll be able to see the Han code or not. So I've given you a lot of information, and luckily we still have plenty of time for questions as well. But what should I do if? And so I tried to think of kind of our overarching things that we're talking about today. What are things that I could do? So what should I do if I think I am experiencing a prescribing cascade or someone that I'm caring for is doing so? So you can ask, is this new symptom, could it be related to a medication that you're already taking? So this could be something of, we mentioned that drug interactions can actually make it that it's not the new medication that got added. Maybe it's now making another medication give you a side effect you didn't have before because the body's not utilizing it the same way. That medication list that I mentioned for keeping a medication list, try to include when did you actually start that? So when's the first time you got that prescription? Because if you have that on there, then for me, if I were to look at it and you were to meet with me and we're trying to see, they call it deprescribing, of taking away medications you don't need anymore. If I wanted to look and deprescribe, if there are general start dates on there, it helps me to see, oh, this might have been started, this was started after this medication, and that's a common side effect of that medication. But if I just have a list, I don't necessarily know that, or I can kind of guess. But if you have some general start dates, that can help to really identify those and make that pattern. Now, what should I do if I believe my medications interact, or the person I'm caring for, that their medications interact? So if you think it's with another drug, you can always ask a healthcare professional. So maybe you've looked online and you're seeing that it does say there's a drug interaction, or you read the package insert. You can ask a healthcare provider, I'm seeing this information. Is this something that you would consider to be clinically relevant? So I mentioned to you when I told you about some of the databases, there's things that will flag on there, and I may not feel that it's relevant. Of like, yes, it theoretically could do that. For you, I'm not worried because this reasoning. So asking if that actually is something that you need to be worried about. You can also ask if there's any labs or monitoring to anticipate. So what would I want to be looking at? Like the one that I mentioned earlier that I caught this morning was that we needed to get an EKG to look at their heart rhythm. And so luckily they have been doing that. And therefore I was able to see, okay, this is starting to actually impact your heart. And now's the time that I have to say this probably isn't safe. And let's see what we can do about it. If you think that the interactions is related to scheduling, then ask how to best take your medications. Is there, medications that you would recommend I take in the morning, ones that would be good for me to take at lunch, ones that would be good for me to take at bedtime. So actually seeing if there's a way that you could optimize that regimen. And if you've been proactive or kind of gather this information in advance to know what drug interactions might occur, then definitely take that initiative and contact a healthcare provider if you notice these signs or symptoms of what you learned to watch out for. So knowing what to look for is going to help you to potentially intervene at that point of realizing, I think I am actually experiencing this side effect or drug interaction at that point in time. Now I threw a lot of information and I saw that some things were popping up. Would you like me to just go through those questions, or how do you want to do these? You're muted.
I had external noise here.
Oh, you're good.
Yes, please go through those. That would be great.
Okay, I'll do that first. Okay. Okay, so one of the questions is, how can you get an appointment to review with a pharmacist? So part of that, and it's very frustrating sometimes to actually try to get in contact with pharmacies. I hear that from the patient side and from the provider side of knowing there's definitely staffing issues and stuff as well, not trying to make that as an excuse, but there's definitely less pharmacists available than there used to be in the pharmacies. So it used to be a lot easier to call and get that information. So I definitely would encourage you, if this is part of it, asking if you're able to go in person and pick up the medications. At the pharmacist there, you might be able to get them easier. They generally prioritize kind of who's there in person versus the phone calls that you might have more access to them. There is also, sometimes your insurance companies actually partner with pharmacists. And so that might be a way, is asking your insurance company if they have any programs available for you to look at that. They often call it MTM, or medication therapy management. That they are actually partnered with some pharmacists that help to go through medications. So the insurance might be a good option. And then I also mentioned ASCP, so American Society of Consultant Pharmacists. There's somewhere on their website that says like, find a consultant pharmacist. And so those are people that have volunteered to have their name out there. And some of them have programs that they will actually meet with you. There's sometimes cost associated with that, or they might partner with your insurance agency, but that's another way you might be able to find a pharmacist. I saw there's some questions about the website. And so that is in my in the PowerPoint, which I'm happy to share that too.
Mm-hmm.
And some pharmacies do have appointments, like you mentioned that yours, you were actually able to schedule appointments.
Right.
That if they're able to do that, they kind of would put them into their schedules, like where they would normally put a vaccine schedule. They can put someone on there to review medications. Were you going to add to that?
I was just going to say that, yes, I asked for the appointment. The one lady had asked, she had to go to another PowerPoint presentation. And so she was asking for the beers link. And I don't know that I gave her the one that you were making a reference to. So that was that answer to that question. Okay. What is the link that you think is the best to go? And I can enter that if you need me to.
There's one in, let's see which slide it's in. Don't want to make you guys dizzy going back through all of these, but
I was probably answering that question when you were going over that.
It's this one right here.
Got it. Got it.
So that link, I went to it, like not logged into my computer at all, and I was able to open it, and it looks like it's open access.
So everyone, what slide number is that? I can't tell from mine. Can you?
Slide 7.
Slide 7.
Mhm.
I'll put that into the notes just in case.
Okay, common for primary care to refuse to prescribe benzo-Xanax to anyone. My mom needs it sometimes, but they will only prescribe buspirone. They used to give her Xanax as needed. So this is a growing thing that you're seeing, is that some providers will flat out refuse to prescribe them. Part of that can be inappropriate interpretation of some of these guidelines that I mentioned today. So like the Beers criteria is not saying that this is always inappropriate. There can be times that it is appropriate. If we're comparing buspirone to Xanax, I don't know that much about your mother's case to give specifics, but things they could, if she had respiratory conditions, that could be a reason why they don't want to. There could be interacting medications that they don't want to. There are some providers that truly just don't want to have to get involved with the extra steps involved in these agents, and so they're just not going to prescribe them. So there can be multiple factors, but you will sometimes see that people may not be willing to prescribe them. Okay, yeah, and that's that information. Okay, so supplements. So some supplements will show up in drug interaction databases. So you can sometimes see the supplements and what they will actually do. The take 2 per day with food, but together, those are things, definitely good questions that I need to know more of the specific supplements to really be able to answer that. And so going to a pharmacist or looking at those interaction checks and seeing what they say would be helpful. The ones that interact the most are things like calcium and iron, because those are binders. And so they'll actually bind to other medications. And so that's why we have to avoid those. Versus a lot of other things, it's not too big of a deal. And then don't take with melatonin. So melatonin is more of like a bedtime one. I will tell you melatonin is kind of one of the growing scary over the counters, because melatonin dosing is, you're really supposed to use low doses of melatonin for it to be effective. And we have this innate belief that more is better, right? It's always more is better means it's going to work better. But with melatonin, if you take higher doses, it actually can cause insomnia. And you might not realize the insomnia, but it does kind of cause more nightmares, etc. That's something that we need to be considering, that low dose is actually better with melatonin than high doses. And when I say low dose, I mean like 1 to 3 milligrams. When doses start going over 5, they've found that melatonin actually can start causing insomnia. So I've seen people on, because again, it's over the counter, taking like 20 milligrams of melatonin just because, well, it's over the counter, it's probably better if I take more. But with that one specifically, we want those low amounts, but it doesn't really interact with other medications if you're thinking of taking it at the same time as other ones. And then interactions with happy hour alcohol. So we don't have a ton of big drug interactions with alcohol. The one that I mentioned was metronidazole, is something that you absolutely do not want to take with alcohol before or after, because it's going to completely reject it and you're going to be very nauseous and not feel good. Alcohol is a CNS depressant. So when I told you about the CNS depressants earlier, and they say limiting that use to no more than 3, that's something that I would consider. If happy hour adult beverages are a normal thing, then kind of wanting to be very cautious with those CNS depressants, realizing that they're all CNS depressants or using them together. Okay, yeah, and then you were answering about medication therapy management type 1s. Bydureon shot for diabetes contraindicated if your esophagus had to be stretched to swallow. Yeah, so I can't remember the verbiage of the actual contraindication, but there is one, and it has to do with, I thought it was esophageal strictures. But this would be a similar type thing, that if the esophagus was just that tight, that they don't recommend this one, because it does slow the ability to gastric emptying further down the line. And so if the esophagus also has this issue, then the food's really not going to move when those are combined together. And best if you have this esophagus problem. So the things that they generally will use, metformin, really most of the other classes are okay. It's more just that injectable, that class, that those GLP-1s that are limited, but the other ones are generally okay. I think it's even with the DPP-4s also work in a similar way to try to stop appetite, but it's not the same mechanistically. So even those are all right. Most of the other ones are fine with esophagus problems. What other questions can I answer?
Folks, if you want to ask, you don't have to put it into written format. I can do that after she's answered the question.
Ozempic would be a similar mechanism of action, so they probably wouldn't use Ozempic either. If they were doing an injectable, it would probably be insulin.
Questions?
Hi, my name is Kim, and I'm just concerned. My mother just recently went on palliative care, where they've increased her hydrocodone and added morphine.
Mhm.
And it's a different doctor, and they're telling her to take like Benadryl for the morphine itching side effects. And I'm just kind of confused to how much communication they're having with her internal medicine doctor. I mean, where do I start to make sure that we're not having some interactions here?
Okay. Is she on palliative care or hospice? Do you know?
She's on palliative care.
Okay, just because that is a different way to answer the question because they're slightly different. So usually palliative care, they are pretty good about helping to coordinate with those different positions. If you have, what I would recommend is really trying to focus on, we have palliative care on board, but still hopefully only one of those providers is the one that is managing the pain medications. So is it them or is there a pain management doctor involved that they're collaborating with? Would be one thing to consider.
No,
So it might be that
the senior care center is the only one that's prescribing her 10 milligrams of hydrocodone, and then she gets 15 milligrams morning and night of morphine.
Mhm.
But then we started having some itching side effects, and so she said to take the Benadryl. And the Benadryl, I've just always heard, and even was kind of reinforced through your presentation here about the side effects with it, with some of her current medications she takes for, she takes Xarelto and she takes diabetic medications. And it kind of concerns me adding that nobody really knows that we've added the Benadryl.
Mhm. So I would think, one thing that you could potentially do if she's kind of like constantly itching, is seeing what their thoughts would be on instead doing something like a Claritin or a Zyrtec every day. Because they don't work as quickly as Benadryl, so that's usually why we don't use them as needed.
Okay.
But if it's more constant itching, one of those would help to at least kind of have some baseline to decrease that itching versus
And
the
that'd be
Benadryl.
better than the Benadryl.
Yeah, the Benadryl is more effective for itching because it does work faster. But if we're
Yeah.
having to use Benadryl a lot, it's better to switch to something that doesn't cause all those CNS issues.
Right, because I just worry about cognitive issues. She
Mhm.
kind of just, it kind of comes and goes. Her mental status, I guess. So I
Yeah.
just kind of worry about that.
Yeah, it's really hard to, and I know that the great thing often, at least in my experience with palliative care, is when palliative care is on board, they are usually very involved and can kind of help advocate too. So if you have those concerns, sometimes they're a good provider to go to voice
Okay.
that.
Well, they have been really good
Mhm.
with everything so far. So we're really pleased with that. Well, I sure thank you.
You're welcome. Mhm. Yeah, if we can avoid it, as someone just said, I always try to avoid it. But I know that there's times that we truly need it. Like I mentioned with my Nana, she had a terrible allergic reaction. And so that kind of, we just used Benadryl. We only intended to do it for a couple days and then take it out. But in that situation, we just forgot. Yeah, if you can avoid it. And that compounding of dementia risk factors too, it's that they're finding these anticholinergic medications. We think that there's probably, if you take it for like a certain amount of time, or you're taking a certain amount of anticholinergic all at once, that is a risk factor for dementia, but they have not been able to actually tell you what that amount is yet. So that's why we just generally take this approach of let's try to minimize anticholinergics as much as we can. Okay, so best diabetes pill if you cannot take the shots, you're insulin resistant. So there's a lot of oral options now. Like you have metformin is definitely one of the longstanding good medications that can be used. There's a new class called the SGLT2 inhibitors. They end in gliflozin. So there's a lot of names that are hard to say, but that's what they end in. That those are big ones that people are using. I mentioned the DPP4. So those are your gliptins, that those can be helpful. Sulfonylureas are effective. So things like glipizide, glimepiride, but those are effective, but have a really high risk of causing hypoglycemia. And in hypoglycemia is a big risk for falls. So those are actually all on the Beers criteria to try not to use those sulfonylureas. But as I mentioned before, if we don't have options, we can monitor people closely if we have to use things like that from the different factors that you've mentioned that may limit some of our other options.
Other questions? It's almost coming up on the hour, but I have a question that may be a little off topic, but perhaps not, since you are also very much into caregiver advocacy and assistance and support. When you have someone that you're caring for, when they are taking multiple medications and from multiple doctors, any hints to help them understand the importance of not picking and choosing their medication because they've always seen Dr. So-and-so and they trust his care and he said it's all taken care. In other words, what kinds of ways could you help us understand how caregivers can support their loved one taking their meds as they should?
That's a hard one because we're all
It is a hard
not
one.
great at taking them. The biggest thing that I can advocate for is being honest in that. So with providers, if you're trying to get them to do so, figuring out what are those reasons for, I like to call it non-adherence versus compliance. That's my preferred term. Because adherence says that we're buying into it, that like we have some say in that plan. And so what are those reasons for non-adherence? Is it that you don't like taking it so many times per day? Is it that you don't like the side effect of that one? It could be because it didn't come from the provider that you trust. And so you're not as willing to do that. So that might be something in that scenario. Maybe they need to go back and talk to that other provider, say it's their primary care is the one that they're really comfortable with, and telling them, hey, my endocrinologist, since we've been talking about diabetes, really wants me to try this one medication, but I wanted to run it by you first. So that they know this has been what's recommended. Kind of getting that extra, yes, that's okay for you to take that, or I would agree, they're the expert. That's a good choice. And that comment, there you go. The doctor said it's true.
Yeah.
For what we see for these, and that, well, they didn't really know. But so sometimes having that support of that person is helpful. But the biggest thing I really can advocate for is just if someone's not taking a medication, making sure that the providers know that they're not taking it, not from it to be a conversation of, you're not taking your medications like you're supposed to, but you don't want them to keep adding medications because they think that something's not working. And so making sure that they know if a medication's not being used, that we are sharing that information, because then if someone suddenly decides to start taking all of their medications, we can have a ton of issues. They weren't taking their diabetes medication, then they took all of them. And so now they're very hypoglycemic and have really low blood sugar because they didn't need to have taken all of those.
I just made a comment, and I don't know if it's clear there. Being a family caregiver at one time, I found that sometimes it helped is to put it in terms of, if we can stay on track with these medications, it's going to help you and me both. And my role is I want to make sure you stay as healthy and safe as possible, which is what these medications are designed to do.
Mhm.
So kind of own it as the caregiver, and that this is a way for the caregiver and the person they're taking care of to be seen as, we're partners in this. I'm going to do what I can do to help you.
Mhm. Yeah, it's good to
And you're
rephrase it. They actually, there was a movement at one point trying to change the word from caregiver to care partner.
Mhm.
And you hear it a lot in Parkinson's, and like Parkinson's support groups, but there hasn't been a full one overall of switching the term.
Mhm.
Because
Makes
I think that
sense.
partnership,
Like
like you
that.
said. Mhm.
Care partner.
Okay. Whereas for non-FDA evaluated new drugs like Prevagen, prescribed drugs like for pains. So Prevagen, this would be one that you could put, it's called apocorin. And so you could put that into a drug interaction one, and it would tell you if it has drug interactions. Prevagen itself doesn't really have drug interactions. It doesn't have a great set of information behind it either, saying that it works well. But I will tell you the Prevagen, oh my gosh, what are they calling it? Prevagen Plus or something. The newest Prevagen that came out actually has a massive amount of vitamin D in it. And you don't realize that unless you truly read the whole label, because the front never mentions it. And so that you would need to watch out for, because vitamin D is in a lot of supplements and you don't want to exceed how much vitamin D you should take. I think it's called Prevagen Plus, but I could be wrong of which one it is. And it has 2,000 units, the international units of vitamin D. And so that already exceeds a normal daily dose that you would need unless you were deficient. So that's just something to realize that sometimes it's the extra stuff in there, not the medication itself. Yes, so the interaction tools. Yeah, so the websites, it was drugs.com and WebMD. They both have interaction checkers on there.
And
there
that
could be
was
other
on
ones out
slide
there.
7.
How much vitamin D is too much? So guidelines basically say you can probably take up to 5,000 international units daily, and that be okay. But if you read the true that it tells you how much you're supposed to have per day, it says 800 to 1,200 milligrams for how much you're supposed to take. Now, if someone's deficient, we can take more than that. But then once they get back to a normal range, we go back down to that, like no more than 5,000 a day. And your level should be greater than 30.
What level is too high?
They don't have a great definition of too high, but I've seen people with levels greater than 100. And that's definitely where I start to say, are probably too high, definitely can stop that supplementation.
What happens if it's too high? Is that bad for you?
They don't know too much about that either.
Because I was low and I was feeling really fatigued all the time. And so I started supplementing, and then I got, higher than I was, but I wasn't above 100, but I was a good level. And according to my doctor, it was too high and I needed to back off on the supplement, not take it. But Dr. Oz says, I think they say the level of 35, but he says you really need to have at least 50 or more. And so I don't know whether I should be taking it or not.
I'd say as long as you're at least 30, if 50 is one that you think is, better, that's okay, but we don't need to go much higher than that.
Okay. So
I'm sorry, go ahead and I can say something later.
the anti-cholinergic, you said you were concerned about falls with those medicines?
Yeah, so they can cause falls because they just kind of make us tired, a little dizzy. I showed you all those other side effects that they also have.
Well,
So they're
that-
very common ones for prescribing cascades.
That diabetes medicine, the SGLTs, like the glyphosate, you said those were bad for falls as well?
Yeah, the sulfonylureas like glipizide, they're bad for falls because they cause hypoglycemia, so that low blood sugar. So things that are bad for potential for falls are going to be things that are CNS depressants. So I told you some classes that are CNS depressants, anticholinergics falls into that category. Ones that can cause low blood sugar. So that's where the sulfonylureas would fall in. And then meds, we really didn't talk about that much today at all, but anything that can cause lower blood pressure. So medications that can cause hypotension. Those are the 3 side effects we think of when we think of falls.
Well, I guess my mom's in trouble. I think she's on all of them, but she has to be.
Yeah, and that's why, I mean, we monitor. That's why we say too, that it's something that we have to think about and see if there's other options. But in some of the things that you've shared, I think there's definitely some reasons that we know other stuff might not be an option. And
Well,
so
they
we
just-
have to monitor.
They just put her on that glizipinate, but
Glipizide.
but I don't know how that's gonna go, but
Mhm.
she can't take metformin because she took it for a long time and she had diarrhea all the time. She didn't realize that was what was causing it. And
Oh, yeah. That
finally
definitely was that.
finally figured it out, but seems
Mhm.
like between me and her, we're nothing but a drug interaction.
Unfortunately, that's how it feels sometimes.
Well, we're very sensitive to medicines, it seems like. So if anybody's going to have the interaction, it's going to be one of us.
I hear you.
Okay.
I have a question regarding the checkers.
Mhm.
I had it come up. I don't know if it was on WebMD or drugs.com, but in the past, I was looking at one of my mom's medicines and somehow I started looking at mine. And they had me on trazodone and Lexapro and then added Wellbutrin.
Mhm.
And I had been on Wellbutrin before, so I didn't suspect that it was causing a problem, but that combination just made me so fatigued and tired and sick and nauseated. I mean, every symptom you can think of, a headache every day. And
Mhm.
I took it for a couple of months before I finally was so sick. I said, I don't know what made me decide to stop taking the Wellbutrin, but I just stopped taking it. And I felt better the next day. I mean, not completely better, but there. And when I talked to my psychiatrist, he said there was no problem with taking those together. So what it told me and what he told me is 2 different things.
Yeah, no, I mean, it definitely, we never know how people are going to react to them, and they don't truly overlap, but they're all ultimately trying to do the same thing. So you can definitely have kind of those interactions, mechanistic ones versus like side effects, like you said.
Okay, it's 10 after 1, and I don't want to keep Dr. Mahan away from her other responsibilities because she did set aside time for us. If there's any specific questions or other things that you need that she has not answered or the links, then you can send me an email at caregiver@att.net. That's caregiver@att.net. And if I can't refer you directly to a website or give you an answer, then I will definitely send that along to Dr. Mahan. Thank you again. We really appreciate it, Becky. A lot of
Thank you for having me.
information, a lot of information. But I think that beers list, there are a lot of people who never knew about that. I didn't until I was at a workshop and somebody introduced that, and it's very, very valuable. So I appreciate you spending a lot of time on it.
Yeah, you're welcome. And that's why I was saying, grab it now because they're going to
Yeah, grab it now. Thank you so much. All right, everybody,
you.
take care of yourselves as caregivers, and we'll be here the first Monday of next month too. Take care.
Bye.
Will we get copies of the slides?
Yes, ma'am.
Okay,
Absolutely.
great. Thank you.
Bye-bye.